So still on our crash knowledge updates for the SCA examination. This is the SCA week. I know colleagues are starting the exam tomorrow, and it's going to run all through this week and till Thursday next week. Let's have a look. Managing short-term insomnia less than 3 months duration. Now, how shall I manage a person with short-term insomnia? So if insomnia has lasted less than 3 months, it's described as a short-term insomnia, and obviously more than 3 months is long-term or chronic insomnia. So consider the need for referral to a sleep clinic or neurology. If symptoms of another sleep disorder are present, so for instance, you could be having symptoms of maybe obstructive sleep apnea or narcolepsy or something else, and you need to be considering referral to either a sleep clinic or neurology for further assessment. Are there any circumstances or stressors that are associated with the onset of insomnia? Obviously, the person is depressed, the person is having work stress, family stress. You need to be talking about those things and finding out whether it's appropriate to be, giving CBT, taking therapy as an option, or even antidepressants. Ensure comorbidities like anxiety, depression are optimally managed. Offer advice on sleep hygiene. Advise the person not to drive if they feel sleepy. The DVLA must be informed if excessive sleepiness is having or is likely to have an adverse effect on driving, such as obstructive sleep apnea, any severity. So any severity. So if it is having or likely to have, and that's where you see that clause, likely to have. That's the clause that catches anyone that has obstructive sleep apnea. So even if a patient tells you with their scoring on the Epworth sleepiness scale, they're scoring maybe 8 or 9 or 10, and they tell you, oh no, when I stop at the traffic, I'm not really feeling sleepy, I don't doze off. You still need to tell them to inform the DVLA, because there's a potential that if they're having obstructive sleep apnea, they could still fall asleep while driving. And that first incident, when it happens, could actually be fatal. So you need to advise them. And why this clause is also important is for medical legal reasons. So as a doctor, you might say, oh, well, the patient wasn't really having sleepiness, while driving. And then they'll use this clause to pin you down as a medical professional. They'll say, oh, okay, it's likely to have an impact on their driving safety. Then you should have told them. And the patient will even deny. The patient will say, well, the doctor didn't tell me. I needed to speak with the DVLA. So obstructive sleep apnea, primary or central hypersomnia, such as narcolepsy, any other conditions or medications that may be causing excessive sleepiness. If a patient is on zopiclone, is on any medication that could cause drowsiness, the DVLA must be informed. Who informs them? The patient should. So you have to advise the patient to inform the DVLA that they are on this medication. For more detailed guidance, see the DVLA at a glance guide if the sleep hygiene measures fail. Now, daytime impairments, with that link, copy link, yeah. If sleep hygiene measures fail, daytime impairment is severe, causing significant distress, and insomnia is likely to resolve soon, for example, due to a short-term stressor. Then consider a short course of non-benzodiazepine hypnotic medications. So non-benzodiazepine, 3 to 7 days. I think zopiclone is the Z drugs are benzodiazepines. So I say non-benzodiazepine. Do not prescribe hypnotics routinely. Use only short courses if acutely distressed. Do not prescribe hypnotics to older patients or women who are pregnant or breastfeeding. If sleep hygiene measures fail, daytime impairment is severe, causing significant distress, and insomnia is not likely to resolve soon. And you should be thinking about what's called CBT for insomnia. So CBT for insomnia typically involves behavioral interventions such as stimulus control and sleep restriction, cognitive therapy, relaxation training, and can be provided face-to-face or digitally. Consider the need for adjunctive treatment with a short-term hypnotic medication like zopiclone, zolpidem, AZ drug, or prolonged release melatonin if over 55 years of age. So if the patient is elderly, you should be very careful with medications like zopiclone or zolpidem. You should be thinking more about a modified release or prolonged release melatonin. Do not prescribe hypnotics routinely. Use only for short courses if acutely distressed. Do not prescribe hypnotics to older people. Question is, what's definitely older people? I think the NICE guidelines should always specify what they mean by older people, but that's a vague statement. And yeah, if patient is 55, as they've written here, or 56, are they classified as older people? Or is it above 65? The NICE guidelines should always specify what they mean by older people. Or women who are pregnant or breastfeeding. If a hypnotic is prescribed, consider the duration of action. So short acting is usually most appropriate. Consider adverse effects, interactions, and potential for dependence and abuse. Short acting is more important, it's more appropriate. So the person can take it close to bedtime, sleep and wake up without having the adverse effects of daytime drowsiness. Use the lowest effective medication for the shortest period of time. Do not continue treatment for longer than 2 weeks, preferably less than 1 week, actually. Inform the person that further prescriptions for hypnotics will not usually be given. Ensure that the reasons for these are understood and document these in the person's notes. Do not issue further prescriptions without seeing the patient again. If there has been no response to the first hypnotic, do not prescribe another. If there has not been any response, you prescribe Zopiclone, and the patient hasn't really benefited from it. There's no point in prescribing more Zopiclone. You should be thinking about CBT for insomnia. You should be considering maybe should you be trying to prolong release and modify release melatonin patients, especially patients above 55 years. Provide patient information on insomnia, such as Mental Health Foundation, how to sleep better, NHS Insomnia, Royal College of General Practitioners, top tips, insomnia add-ons. So you need the SCA, for instance, you'll be telling the patient that, okay, I would like to send you an information link where you can get more information about insomnia or sleep problems. So hopefully you get information that will help make things better. Then you should be talking about the need to review the patient, and then could always refer for CBT for insomnia, CBTI. Arrange follow-up for review, for example, 2 to 4 weeks, depending on the clinical situation. If symptoms have not improved, reassess the person, consider CBT for insomnia if not already offered. Consider an alternative diagnosis and consider the need for referral. Do not recommend over-the-counter treatments for insomnia. So you can see that do not offer, because some patients can buy phenergan, promethazine, which is an antihistamine, sedative antihistamine over the counter. They do not recommend that for insomnia. It's usually good to know what the NICE guideline says, in this kind of exam. Even though, of course, in actual practice, people might recommend some of those things, or patients might tell you they're already taking it. Even for the SCA, which is a professional exam, standardized, you need to be doing what the NICE guidelines suggest or recommends. What advice should I give regarding good sleep hygiene? So sleep hygiene aims to increase awareness of behavioral, environmental, and temporal factors that may be detrimental or beneficial to sleep. Advise the person on normal sleep and changes in sleep patterns with age. So there are certain things that happen. When I did psychiatric rotation, I got to understand that elderly people have aura. Actually, their brains or their bodies require fewer hours of sleep. So as people begin to get older, they begin to have shorter, duration of sleep. And obviously, that usually becomes a concern for them. Waking up earlier, maybe 4 a.m., 5 a.m., they're already up. So sleep environment, a comfortable sleeping environment should be maintained, not too hot, not too cold, not noisy or bright. The bedroom should only be used for sleep and intimacy. Checking or watching the clock throughout the night should be avoided. So probably if you think you're prone to that, remove the clock, take the clock to the lounge, or keep the clock in your box. For bright light, including all technology, should be minimized, but especially phones. It's so common for us to keep looking into our phones, 10 p.m., 11 p.m., we're still watching YouTube or something. So that's a bad habit. So it's poor sleep hygiene. Blue light displays on electronic devices and television suppress melatonin production. That's why once the weather starts getting dark, you start feeling sleepy because darkness triggers melatonin. Light reduces melatonin production. So avoid using devices for 2 hours before bed. Regular sleep schedules include going to bed when sleepy. Avoid going to bed too early. Very important. Waking up and getting out of bed at the same time every morning, including weekends, and after a poor night's sleep. Increase exposure to bright light in the morning. Avoid napping during the day. So that's another thing that can help with ensuring the patient is getting more hours of sleep at night. So avoid napping during the day, something you need to be telling the patient as well. Obviously, you should be sending them an information link, but you should be able to explain some of these important sleep hygiene during your consultation. Relaxation before going to bed, for example, reading a book, having a shower, having a bath. Relaxation exercises in the early evening may help reduce hyperarousal. A free audio guide on progressive relaxation techniques is available on the Mental Health Foundation website. Visual imagery in bed can help with racing thoughts. Information on mindfulness can be found at the Mental Health Foundation's dedicated mindfulness website. Limiting or avoiding caffeine, nicotine, alcohol. Caffeine should be avoided after midday. And nicotine, alcohol, large meals within 2 hours of bedtime. Alcohol intake is a common maladaptive self-treatment strategy in insomnia, which can contribute to poor sleep maintenance. So what they're saying is that lots of people who will start experiencing insomnia try to use alcohol to knock themselves out so they can sleep better. Well, of course, alcohol, once it happens, that you can really become dependent on it, and you start having withdrawal symptoms, agitation. Obviously, you become more at risk of malnutrition, because many cases, encephalopathy, psychoanalysis, in addition to other harmful effects of alcoholism, and even depression and anxiety. Exercise should be avoided within 4 hours of bedtime, but it's beneficial to exercise during the daytime because obviously to improve your overall health, your weight management, your cardiovascular reserve, to improve your, exercise and obviously improve your mental health, your mood, and improve your sleep hygiene, sleep pattern as well. So these are important things we should be telling our patients for insomnia. And let's look at if the patient has chronic insomnia, what then happens? Let's look at that one. How should I manage someone with long-term insomnia, more than 3 months duration? Consider the need for referral to a sleep clinic or neurology if symptoms of another sleep disorder are present. Now, address any triggers or factors associated with maintenance of insomnia, for example, illness or other stressors. Ensure comorbidities like anxiety, depression are optimally managed, and then offer advice on sleep hygiene. So it's very similar management, whether it is less than 3 months or longer than 3 months. Advise the person not to drive if they feel sleepy, and the same thing, the ADLA must be informed if excessive sleepiness is having or likely to have an adverse effect on driving, like we having obstructive sleep apnea, even if it's mild, moderate, or severe. Well, obviously, if it's obstructive sleep apnea, the Epworth Sleepiness Scale score usually will be 12 or more. Primary or central hypersomnias, such as narcolepsy, any other conditions or medications that may cause excessive sleepiness. Offer cognitive behavioral therapy for insomnia as first-line treatment for chronic insomnia in adults. So chronic insomnia, which is insomnia lasting more than 3 months, thinking more of CBT than a short-term, zopiclone or zolpidem. I mean, if they've had this for longer than 3 months, then a 3 to 7 days course of zopiclone may not really be enough, to put them back in rhythm. Now, CBT insomnia typically involves behavioral interventions like stimulus control, sleep restriction, cognitive therapy, and relaxation training. So that sleep restriction, I believe, is like avoiding daytime napping. So obviously you can then sleep more at night. So you deprive yourself, you restrict yourself of sleep during the daytime, and then postpone most of your sleep till the night period. Pharmacological therapy should be avoided in the long-term management of insomnia. However, some people with severe symptoms of acute exacerbation of a short course or a short course of hypnotic medications, preferably less than 1 week, may be considered as a temporary adjunct to behavioral and cognitive treatments, which makes sense. Obviously, you still want to try some zopiclone or zolpidem maybe for 3 to 7 days, but usually be advising the patient that is a very short course and that even if it doesn't work, or even if it works and patients carries on having insomnia, you're likely not going to prescribe, because the most important thing, to be honest, is the talking therapy, cognitive behavioral therapy, which involves, several counseling sessions that will help to, modify certain behaviors, and also our thought processes around sleep. For people over the age of 55 with persistent insomnia, treatment will modify release melatonin may be considered. Now, the recommended initial duration of treatment is 3 weeks. If there's a response to treatment, continue the melatonin for another 10 weeks. Discuss the risks similar to those of hypnotics, including falls and fractures associated with melatonin treatment in the elderly. Because what melatonin, so normally melatonin is a physiological hormone produced by the pineal gland. Pineal gland isn't it here in the brain? And what melatonin normally does is that as night falls, as darkness comes, it begins to stimulate, or as lights, the amount of light going into going through your eyes, your brain begins to decrease, which of course, as light goes down, means darkness falls. So your melatonin begins to be released, and what it does right now begins to make you feel sleepy, which normally should happen at night time. So giving melatonin obviously will increase the patient's risk of falls, because the person will be sleepy. Because obviously it's an exogenous melatonin, it's not going to be as regulated as endogenous or natural melatonin. So it's just there in your body, and the patient might wake up in the middle of the night and still feeling very sleepy. Obviously, at risk of fall because they're elderly. It could be frail as well. Provide information on insomnia, Mental Health Foundation, how to sleep better, NHS insomnia, RCGP, top tips insomnia in adults. Arrange follow-up for the patient, maybe 2 to 4 weeks, depending on the clinical urgency. If symptoms have not improved, reassess the person, consider alternative diagnosis, and referral. Let's look at this alternative diagnosis. Put it there and see. We'll come back to it. Now, when should I refer someone with chronic or long-lasting or insomnia to secondary care? Refer the person to a sleep clinic, specialist with advice in sleep medicine or neurology. So you can say sleep clinic, specialist in sleep medicine, or in neurology clinic. If another sleep disorder such as parasomnia, narcolepsy, obstructive sleep apnea is suspected, if there's doubt regarding the diagnosis, you should consider referral. Seek specialist advice or consider referral to secondary care. If treatment in primary care has failed, if insomnia occurs in a person from an occupational at-risk group, for example, professional drivers, so long distance professional drivers having insomnia, you need to be very careful. Some of them might tell you to stop smoking, stop driving. Some might even tell you that they're going to speak with DVLA and they will not. They'll carry on driving. Because probably that's the only way, that's maybe their sole source of income. And they don't want anything that will compromise that. So do not routinely refer adults with insomnia, checks on falling asleep, or isolated brief episodes of sleep paralysis. Checks on falling asleep, like my clinic checks. If I see that as a GP, I'm likely want to get advice and guidance, from the neurologist or the sleep specialist. From having checks on falling asleep. Now, what else could it be? The patient is having insomnia. What are the differentials we should be thinking about? Consider other sleep disorders like obstructive sleep apnea, circadian rhythm disorders, restless leg syndrome, narcolepsy, may present with falling asleep in the daytime without warning, and collapse or muscle weakness triggered by emotions. So the patient having narcolepsy, for instance, because narcolepsy is like just fall asleep so suddenly. It's so absurd. Like I can be talking the way I'm talking at the moment, next I just fall asleep. That's not normal, right? That's never normal. So that's narcolepsy. Like this really drastic, immediate switch, like a switch. Someone is fully awake and the next thing they're sleeping. That's like it's a switch. If the person is having parasomnia, so parasomnia may present with unusual or unpleasant experiences or behaviors, like of course, like the jacking, someone is jacking, but someone is, falling or rolling or falling off the bed, you know, frequently. Those are parasomnias, abnormal behaviors or, experiences associated with sleep. And sometimes some of those parasomnias might also be a clue that this person might be developing some Parkinson's disease. The patient is having leg jerks and person is falling off the bed. I'm like, okay, could they have been developing some Parkinson's or some motor, some motor problems? Another thing for the SCA that we need to be checking is restless leg syndrome. Someone is having problems with their sleep. So, okay, do you experience any uncomfortable, sensations in your legs? That can be asked in one sentence, and the person say, "Oh no, 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 yes or no." And once the person says yes, and he has to now explore for how long has that been going on. Have you got a clue what could be causing that? And do you also experience any pain in your legs, any cramps, anything like that? And you start thinking, cues, but and you're like, okay, how to what impact, to what extent do you think this, leg sensations is affecting your sleep? They might tell you, I think that's really what is going on here. Yes, oh, this is likely a case of restless leg syndrome leading to insomnia. And then you should be treating both the insomnia and the restless leg syndrome. You just want to bring that patient in, you want to do some blood tests, like checking their kidney function, their full blood count, their liver function, the iron levels, and vitamin B12, folic acid, and all that things that can affect, that can contribute to restless leg syndromes, or things that can cause abnormal sensations in the limbs, burning feet, and all those things. Those are things we need to be looking at. Food like that, melatonin Z drugs. Okay, something else I found I want us to look at briefly. Not this. Let's go to isotretinoin. Something I saw in the GP notebook. I think we just need to breeze through before our SCA. And that is isotretinoin. Remember, isotretinoin is a medication that is used in secondary care for the treatment of recalcitrant acne. So you've tried all your topicals and your oral antibiotic combination with topicals and things are not just working, and eventually begins to have severe psychological impact or having scarring, nodule cystic acne and scarring. You should start thinking of referring the patient to hospital, to dermatologist for isotretinoin, and the common trade name is Roaccutane. I found this isotretinoin as sexual dysfunction, so I never really knew that isotretinoin can actually cause sexual dysfunction. It says the use of isotretinoin may be associated with sexual dysfunction. Suspected adverse effects include erectile dysfunction, decreased libido. Why am I saying this? The patients could come with symptoms of erectile dysfunction. When you're doing your medication history, they tell you they take isotretinoin for acne. So decreased libido, vulvovaginal dryness, orgasm difficulties, genital hypoesthesia, so like reduced sensation, genital areas. That's really going to be quite weird for the patient. Patients should be asked about the presence of symptoms or signs of sexual dysfunction prior to starting treatment with isotretinoin and be monitored for the development of new sexual disorders, including treatment. Age and maturity of the patient should be considered in choosing the most appropriate counseling approach, including giving the option to discuss without parents or carers present where appropriate. Like maybe a young patient, a young male patient who is on isotretinoin started by a dermatologist and is not coming to tell you that he's developed weak erection or impotence and he's really worried about that. So you need to be able to say, okay, fine, I think this is likely related to this new medication you started, isotretinoin, for your sports, for your sports. I think we need to get back to the dermatologist and ask them for advice on whether we should be stopping this medication. Obviously, you would have checked if the patient is having morning erections, are they feeling anxious, have they got a new partner, how are things at home, what did they do in terms of work, are they having any stresses, is there anything that's recently happened, that is making them really stressed and things like that. So you want to rule out the psychogenic or psychological cause of the erectile dysfunction before pinning it down to the medication. Okay, patients you asked here, and be monitored for development of new sexual disorders during treatment. Now, the age and maturity of the patient should be considered in choosing the most appropriate counseling approach, including giving the option to discuss with our parents. Okay. Isotretinoin has both serotonin reuptake inhibiting and 5-alpha reductase inhibiting properties. I never knew that. So isotretinoin, so it has SSRI effects, which is why, of course, SSRIs can cause sexual dysfunction. It has the 5-alpha reductase inhibitor effects. Medications like finasteride and dutasteride, they're 5-alpha reductase, they're used in treatment of BPH to shrink the prostate. The 5-alpha reductase inhibitors, what they normally do is that they block the conversion of testosterone to dihydrotestosterone, isn't it? I think, yeah, to dihydrotestosterone. So they prevent the activation of testosterone essentially. Now, but it is not clear whether the problem stems from either of these actions. Okay. Now, advice for healthcare professionals. All patients must be counseled about the benefits and risk of treatment before isotretinoin is prescribed, including possible mental health and sexual function side effects. We also ask the referrer, usually the GP, to provide information about isotretinoin to the patient and provide counseling where possible regarding the benefits and risk of isotretinoin treatments. So generally, of course, the dermatologist, I presume, will be going through these kind of discussions with patients. But it's really good as a GP when you're referring the patient to secondary care for acne treatment, you're telling them what they will likely encounter. In terms of very likely, you might be prescribed a tablet called isotretinoin, but that is it's usually we're advised to inform you that this medication can come with some side effects, like affecting your mental health, for instance, and causing some sexual problems. So they have a clue. What are your thoughts on this? And they might like, okay, well, that's quite a difficult one, although obviously they likely will still want to be referred. Isotretinoin is teratogenic. All patients of childbearing potential must be entered into the pregnancy prevention program. It must be entered into usually for isotretinoin, I think it's isotretinoin that when the patient is on isotretinoin, they should have pregnancy tests done 1 month before starting it, and they'll keep having pregnancy tests every month up to 1 month after stopping it, because it's a highly teratogenic medication that you just want to identify any pregnancy, because any pregnancy that happens has to be terminated. There's a high chance that the baby is going to be severely malformed or deformed. Prescribers should assess patients' mental health before prescribing isotretinoin, including the use of patient-reported outcome measures. Ask patients about any sexual function concerns before prescribing isotretinoin. Give the patient sufficient time to consider, reflect, and ask questions before starting isotretinoin treatment. Use the new regulatory risk minimization materials with all patients. The lead prescriber who initiates isotretinoin treatment must have expertise in the use of systemic retinoids for the treatment of severe acne and a full understanding of the risk of isotretinoin therapy and monitoring requirements. Now, initiation of isotretinoin treatment in patients who are under 18 years of age now requires agreement by 2 independent healthcare professionals that there is no other appropriate effective treatment before it is prescribed, which means you should really have a high threshold for referring patients to the dermatologist for acne treatment, which means you should have really considered and you should have really tried to the maximal possible, levels, your topical treatments and your oral antibiotic combined with topical treatment. You should have tried that over and over and over until it has to be absolutely clear that these things have not worked before you begin to consider referring these patients for isotretinoin concentration obtained. Review patients approximately 1 month after initiation of treatment in a face-to-face appointment. Monitor patients for side effects. Okay, the GP is calling me. So this means that isotretinoin should only be prescribed for severe acne that is resistant to courses of standard therapy, exactly what we said. So review patients approximately 1 month after initiation of treatment in a face-to-face appointment. Monitor patients for side effects, including mental health and sexual function. Side effects at each appointment, including objective mental health, patient-reported outcome measures. Any healthcare professional who is involved in treatment of patients with acne, particularly prescribers of isotretinoin, should review the full details of the new requirements in the report of the Commission on Human Medicines. Isotretinoin Implementation Advisory Expert Working Group. Report suspected adverse drug reactions associated with isotretinoin on a yellow card. That's really, really important. Let me see if we can do red eye. Got any red eye? Yes, look at red eye differential diagnosis, red eye general practice. Let's have a look at this. I'm not sure if it's going to the SCA. I'm thinking the SCA might actually be something. I'm not sure. Anything could come out. Red eye could actually come out because they might just want to see how you manage, red eye. A patient could come with a subconjunctival hemorrhage, for instance, and the patient is really worried about it, that you need to be, or your red eye needs to be finding out is something that is potentially serious or is something that is not that serious. Let's have a read. Conjunctivitis, dry eyes, and foreign bodies are the most common causes of red eye in general practice. Treat as an emergency anything you don't come across regularly, including iritis, acute glaucoma, and ophthalmic herpes. Ophthalmology is a vast subject, and delay can quickly lead to a blind eye. Steroids must be avoided unless you are absolutely sure the eye is not infected, such as in recurring iritis. Because if the eye is infected and you're putting steroid and you have a setback, all steroids generally do that. Because they're immunosuppressants, right? They suppress the immune system, the steroid flares up. So if it's a keratitis, for instance, infective keratitis, and you use steroids, what's going to happen is that you could worsen that keratitis, which will lead to severe corneal scarring and blindness. Be suspicious of a unilateral red eye. Infective conjunctivitis is usually bilateral by the time it presents. Itching is nearly always an allergy. So if there's an eye itch, it's usually reassuring that it's likely allergic. Chromoglycates is safe and works well, but nedochromyl sodium needs to be used less often. So chromoglycates eye drops are usually they're actually quite readily available over the counter. To instill eye drops, pull down the lower lid, okay, especially in children. The lid is much less sensitive than the eyeball. So you can pull down the lower eyelid and then you put the drop on the lower eyelid. And then by the time you close and open your eye, it just disperses on your eyeball. Chloramphenicol causes aplastic anemia, so extremely rarely causes aplastic anemia, so extremely rarely. Okay, it can cause allergic blepharitis in chronic use. Chloramphenicol eye drops must not be given to children who are less than 2 years old, as it contains boron and may impair fertility in the future. Really? I knew that. Like, in terms of the fertility aspects, must not be given to children who are less than 2 years old. It contains boron and may impair fertility. Now, this is where some complexity may come in. So your mom could tell you that an 18-month-old child has red eyes, gonky red eyes, and they're like, should we use chloramphenicol or not to treat this baby? And it should never be used and impair fertility. So these are areas where you need to start explaining that you need to speak with the ophthalmologist, You need to, of course, if it's a newborn baby, you need to be taking eye swabs because you're thinking of new ophthalmia neonatorium, chlamydia, or gonococcal ophthalmitis, or things like that. So, depending on the age of the patient, your approach will differ. But it's actually worth knowing that you might be good for me to blonde than your SC, for instance, if you're prescribing chloramphenicol eye drops to a child who's less than 2 years old. Obviously, the ophthalmology department might prescribe it, but to be off license when they've balanced, but they will probably use other options like gentamicin eye drops, when they balance pros and cons. Let's see if we go back. Referral to ophthalmology opinion. So let's have a look. In general, red eyes presenting in primary care are most often secondary to conjunctivitis, which could be infective or allergic conjunctivitis. If there are any features suggestive of either iritis, acute glaucoma, a foreign body, or any other significant cause of a red eye, then immediate ophthalmological review is required. So once you're getting from your history, things you're thinking iritis or glaucoma, patient is having pain, with tunnel vision, for instance, they've got a family stroke glaucoma and you're worried about glaucoma, obviously painful red eye needs to be, because any painful red eye, you need to be referring to ophthalmology. If they've got foreign body, they say the redness of the eye started, maybe they were welding or they were doing some garden work and salt went into the eye and since then it's been red, uncomfortable, you need to be, you can bring them in, do a fluoroscopy, fluoroscopic examination. Obviously, in the SCF is a video call. You're seeing the patient's eyes. You could tell them to come closer to the screen. You have a look if it's red and all that. Go speak with the ophthalmology on call for them to do a slit lamp examination. Fluorescein dye, not fluoroscopy. It's a fluorescein dye stain slit lamp examination to make sure they've not developed a corneal restoration or aberration. Example of when ophthalmological review is required include if there's an impairment of visual acuity, if there are abnormal pupillary reactions, if conjunctival injection is most marked around the pupil, suggestive of keratitis, corneal ulcer, or intraocular pathology. If there's corneal ulceration, which usually you see when you use the fluorescein dye, or if there is a history of possible penetrating injury, if the fundus appears cloudy, or if there is associated significant pain rather than the gritty discomfort as felt. So conjunctivitis usually come with that gritty, sandpaper feel, or uncomfortable, it feels dry and just uncomfortable. But there's pain, significant pain in the eye, you need to be referring. If topical treatment for presumed conjunctivitis has not led to improvement, so you prescribe topical chloramphenicol for like up to 5 days and the patient's red eye has not improved, you need to be referring to ophthalmology. Let's look at etiology in terms of differential diagnosis. The condition may have a variety of causes, red eye, including bacterial conjunctivitis. So there's redness. Redness is peripheral and bilateral with central sparing. The bacterial conjunctivitis usually is obviously conjunctiva, not the cornea. In episcleritis, condition is unilateral and segmental. So episcleritis, usually you will see that redness usually on one side. It's usually unilateral and it's usually segmental. It looks like a fan-shaped redness on the conjunctiva, episcleritis. In acute iritis, redness is around the cornea and unilateral. Corneal surface is dull, small irregular pupils. So once the redness is around the cornea, around the back of the eye, small concentrated around it, you need to be referring for possible iritis. It's more away from the cornea, more away from the iris. The iris is the black part of the eye, so iritis. So if you're thinking of iritis, you should be referring. Glaucoma redness is unilateral around the cornea as well. Corneal surface is dull, mild oval-shaped pupils, no light response. So things that are happening around the iris. Okay. Of course, closed angle glaucoma, the problem is usually at level of the iris, at the iridocorneal angle. That's where you usually have the closure. So the redness is more around the cornea as well. So corneal ulcer, redness around the cornea, the lateral corneal surface. So if you're having redness around your cornea more, you should be thinking it's not unlikely to be conjunctival. It's more likely to be things that happen either iritis, keratitis, iritis, glaucoma. Conjunctival hemorrhage, localized hemorrhage with posterior limit present. So, usually it's usually painless. So these are the things you should be thinking. Is it conjunctival hemorrhage, subconjunctival, is it glaucoma, the eye trauma, is it iritis, is it keratitis, episcleritis, scleritis. So let's look at the scleritis. It's quite long. Things to note is that scleritis, 21% of scleritis are associated with rheumatoid arthritis and other collagen diseases. 12% associated with ankylosing spondylitis, herpes zoster, 15% herpes TB, syphilis, Barrett's disease. Scleritis can be unilateral or bilateral, usually exquisitely painful. Installation of phenylephrine will not blanch the vessels. Now, posterior scleritis is inflammation of the sclera that is behind the orbital septum and is not visible to the casual onlooker. Now, let's look at treatments of scleritis. When you suspect scleritis, early referral is required. The condition is generally resistant to treatments. Topical corticosteroids may exacerbate thinning and destruction of collagen fibers and may increase intraocular pressure. So you don't just rush to prescribe topical steroids to a patient. You might be damaging their eyes. So as a GP, I would say don't ever prescribe topical steroids without the guidance of ophthalmology. Don't. It could be dangerous. Systemic NSAIDs are most usually employed, in particular, oxyphenolbutazone, and indomethacin. They suppress the destructive processes and are continued until a natural remission occurs in the disease. They suppress the destructive processes and are continued until a natural remission occurs in the disease. Rarely, systemic steroids are indicated for the most resistant forms of the disease. Let's go back again and look at clinical features of scleritis. Scleritis presents with severe deep pain and tissue destruction, even leading to loss of the eye. The episclera is almost always involved. So you can see there's episcleritis and scleritis. Episcleritis is milder, a milder disease than scleritis. Typically in episcleritis, there is no pain. There is fan-shaped kind of redness, either on the medial or lateral aspect of the conjunctiva, on the white part of the eye sclera. Episcleritis is somewhat between the conjunctiva and the sclera. A thin potential space between the conjunctiva and sclera. So episcleritis. Or scleritis is on the sclera and inflammation of the sclera itself. It's usually scleritis associated with, you can see that sometimes could be associated with systemic problems as well. And it's usually more, it's more severe, deep pain within the eye. Usually they don't have pain when they move the eye left, right, and there's very severe eye pain and redness. Vision is often affected. There's a focal or diffuse area of redness brought about by dilation of vessels in the subconjunctival network. It may be unilateral or bilateral, and is more common in women than men, and in the fourth and fifth decades of life. The condition is often classified into anterior and posterior scleritis. Both are associated with keratitis, uveitis, glaucoma, cataract, and exudative retinal detachment. So scleritis, if a patient is coming to you in SCA or in real life as a GP with a red eye, the first question you want to ask yourself is, Is it painful? Obviously, how did it start? Tell me about this redness. How did it come on? How did the patient finish checking? The patient hasn't told you whether it's painful or not painful. You need to find out. And the next question is the affectation of vision, any blurring of vision, any colored, abnormal colored vision, any double vision. For instance, you need to be checking any visual affectation. Those are the two important things. And then what is the pattern of the redness? To get the point, is it unilateral, bilateral? Is it more peripheral or is it more pericorneal or is it whatever? You see that around the iris, you know what I mean? Is it more, focused around the iris, the black part of your eye? Those are the things that you should be checking. Right. Is there anything else we need to look at? I think we need to look at quickly ADHD and autism, but let's take a break anyway. We'll do ADHD and autism very shortly.